Good afternoon, everyone. So after such a nice case from the Department of Gastroenterology, from the Department of Obstetrics and Gynecology, we are presenting a very common condition, which is polycystic ovary syndrome. After seeing the complication in pregnancy, so now we are dealing with the patient who is infertile, and with the infertility, actually, these patients were carrying pregnancy. So this polycystic ovary syndrome is very common condition. So, and these patients usually present with infertility, that is their main problem. So, what we are presenting two cases which were actually harboring malignancy and they were being misdiagnosed as polycystic ovary syndrome. So, we have Dr. Ayushi, senior resident, who will be presenting the cases, and Dr. Swati, assistant professor, will review the literature.
Good afternoon, everyone. I'll proceed with the cases. We had two cases. Case one was who presented to us in April 2025 was a 30-year-old resident of Bihar who presented with complaints of secondary infertility and irregular menstrual cycle. And the duration of her secondary infertility was 3 years. She had previous one full-term normal vaginal delivery. The second case who presented to us in October 2025 was a resident of Canada. She was 37-year-old, secondary infertility with irregular menstrual cycle, and duration of infertility was 2 years. Both the patient attained their menarche at the age of 25, at 12 years of age, and they were having a regular cycles. For the past 2 to 3 years, they had delayed cycle and was bleeding only on progesterone withdrawal therapy. Both cases were previously labeled case of polycystic ovarian syndrome with chronic anovulation. Case 1 had received previously multiple OVI cycles with failed response to oral ovulations and HMG and was referred for further treatment and laparoscopic ovarian drilling. The second case had received 3 cycles of OVI with letrozole in 2024 and had a history of one failed IVF in 2025 in Canada. The first case had a BMI of 19 and second case had a higher BMI of 31. Although on examination there was no signs of hyperandrogenism, both patient had a normal vitals. On pelvic examination in first case, there was a mass of 4 into 4 centimeter felt in the right fornix, whereas a mass in the second case was of the size of 5 into 5 centimeter felt in the left fornix. So as they got their previous hormone profile and the baseline hormone LH was raised in both the patients and the LH FSH ratio was also raised, thus making a diagnosis of PCOS previously. But however, they were having a marked increase in AMH that was 18.7 in case 1 and 25.2 in case 2. Other workup for PCOS were within the normal limits. We proceeded with the ultrasound at our center, and on ultrasound in the right ovary, we were able to see a 5 into 5 cross 5 centimeter mass in the right ovary, and it was very highly vascular, and this mass was picked up in a routine scan by our resident. The second case, there was a mass of 5 into 5 centimeters seen in the left ovary. Although the patient had a previous records from 2021 showing a similar mass of 2 into 2 solid mass of 2 into 2 centimeters. Thus, with a marked anti-Mullerian hormone and a solid adnexal mass, we were of the suspicion, are we looking at a case of PCOS or is it a ovarian tumor? So we proceeded, in view of a solid adnexal mass, we proceeded with the tumor markers. The epithelial tumor markers were although in the normal limit, but inhibin was raised in both the patient and we got a serial AMH which showed an increasing trend. Thus, the suspicion of granulosa cell tumor was made. Now the imaging will be discussed by our radiology resident.
Good evening, everyone. So coming to the case 1, on ultrasound, there was a predominantly solid lesion with smooth outer contour and few internal cystic areas. No posterior acoustic shadowing was there. When we put the Doppler, there was a moderate color flow within the lesion. On MRI, on T2 weighted images, there was a predominantly solid lesion with internal cystic areas. The solid areas looks intermediate signal intensity on T2. The contralateral ovary was normal and the endometrial thickness was also normal. So, in summary, on ultrasound, there was a predominantly solid, non shadowing right adnexal mass with few cystic areas, smooth outer contour, and color flow of 3 on Doppler, suggestive of ORAT's 4 lesion. On MRI, the solid component showed T2 intermediate signal intensity, likely malignant etiology. Coming to the second case, on MRI images on T2, there was a predominantly solid lesion in the left adnexa with internal cystic areas. No fat or hemorrhage was there on the T1 weighted images. On diffusion restriction, there was true diffusion restriction of solid areas in the adnexal lesion, and on post contrast images, there was progressive enhancement, but the solid enhancing areas were enhancing less than the myometrium. The contralateral right ovary showed normal morphology with peripherally arranged follicles suggestive of polycystic ovarian morphology, and endometrium thickness was normal. So, concluding the second case, a well defined left ovarian lesion was there, which was predominantly solid, T2 intermediate signal intensity of the solid components, and showing diffusion restriction with internal cystic areas. On post contrast MRIs, there was progressive enhancement of the solid areas, and enhancement was less than of the myometrium. This was suggestive of ORAD's MR4 lesion, which is intermediate risk of malignancy.
Thus, as we had a raised AMH, inhibin B, and a solid indexal mass, a provisional diagnosis of AMH secreting sex cord stromal tumor was made. However, the dilemma continues. Do we have to treat the tumor first, or are we going to plan the fertility treatment first? We had a multidisciplinary team of gyne-oncologist, oncofertility expert, radiologist, and pathologist, and oncological and reproductive outcomes were discussed. A thorough counseling of patient and family were done, and risk and benefit associated with fertility sparing surgery was explained, and further potential complication was explained to them in detail. And we proceeded with laparoscopic fertility sparing staging surgery. As you are able to see in the screen, we proceeded with fertility sparing surgery. We did a staging laparoscopy. In that, we had a peritoneal was cytology, and we did a thorough inspection of abdomen and pelvis. Followed by a removal of affected adnexa was done. As you are able to see that we are clamping the IP ligament, and the capsule was intact. We have not there was no spillage of the tumor, and the capsule was intact, and there was no papillary excrescences or any surface lesions in the above case. It was a very well encapsulated tumor. After the tumor was we did a salpingo-oophorectomy. We proceeded with infracolic omentectomy, and after infracolic we have done the infracolic omentectomy. After that, multiple peritoneal biopsies were taken. And peritoneal biopsies, as you are able to see, multiple biopsies were taken, and all the specimen was retrieved in a bag so that there is no spillage of the tumor. The specimen and the adnexa and the infracolic omentum was placed in the specimen, and an incision was given suprapubically that was about 3 centimeter, and the complete bag was the specimen was removed in bag so that there is no spillage or there is no upstaging of the disease. As you are able to see in the image, the specimen is removed in the bag. We are able to see in both the cases the complete adnexa, tube and ovary, and the omentum. Now I will call my pathology colleague to discuss the pathology specimens.
Good afternoon. I'll be discussing the histopath findings of both the cases. This is the gross image of the first case, and here we can see the enlarged ovaries with the external surface of the capsule. It is intact and giving a lobulated appearance. The cut section of the ovary shows presence of a yellow to tan predominantly solid tumor with few cystic areas which are filled with the mucoid material. This is the HE stain slides of the specimen, shows presence of the tumor which is arranged in predominantly lobular architecture, which is separated by this fibrocollagenous septa. On high power, we can appreciate the tumor cells which are round to oval. They are showing minimal pleomorphism and have angulated nuclei with the vesicular chromatin, and few of the cells also shows this nuclear groove, which is also known as coffee bean nuclei. In this image also, we can appreciate the coffee bean nuclei, which is seen in this tumor. This is the second case, gross image of the second case, and we can see the enlarged ovaries with the capsule which is intact. Grossly, there were no papillary excrescences, and this is the cut section of this ovary, which is showing a tumor which is solid cystic and also has areas which are filled which were hemorrhagic. HE stain slides prepared from second specimen shows presence of the tumor, which was predominantly arranged in insula pattern. The tumor cells are arranged; they were arranged in the small nest, which was separated by this thin fibrocollagenous septa. And on the high power, we can appreciate the tumor cells, which are of the similar morphology as in the first case. They are also round to oval, with showing minimal pleomorphism, and there is vesicular nuclei with coffee bean, this intranuclear grooving we can appreciate on this high power. This image is also put to appreciate the coffee bean nuclei, which can be seen. There were also few areas which was filled with blood. These were the hemorrhagic areas that we could appreciate on the gross images also. IHC was done on both the cases, it shows immunopositivity for inhibin, FOXL2, and focal positive for calretinine. Depending on the basis of the above histopath and IHC findings, diagnosis of granulosa cell tumor was given. Thank you.
As the final diagnosis in both the cases were granulosa cell tumor of ovary, stage 1A, the adjuvant therapy was not required, and post-operative course in both the patients were uneventful. As we have seen the trend of the AMH and inhibin pre and post surgery, as you are able to see in the case 1, there was immediate fall of AMH as well as inhibin post surgery. In the second case also, the immediate fall in the trend post surgery was seen in both AMH as well as in inhibin B. Thus, the menstrual and reproductive outcome of the patient, both patients had a spontaneous return of menses within 1 month of surgery, and the first patient conceived in the first cycle of OVI within 3 months of the surgery, and she is currently in her third trimester. The second case also had a spontaneous menses within 1 month post surgery and is planned for IVF after 2 months. Now I will call Dr. Swati for the discussion.
Thank you, Ayushi. Good afternoon, respected seniors and my dear colleagues. So, why did we choose to present these cases? First of all, there is presentation of delayed menses, and they had withdrawal bleeding only on hormonal therapy, which we commonly encounter in our OPD, although they had associated infertility along with follicular resistance to both the oral induction agent as well as gonadotropin, which is not that commonly seen, and these patients then had markedly elevated AMH levels along with the detection of solid adnexal mass. So now we were thinking that this is something beyond the PCOS, and we are navigating from the polycystic ovarian syndrome to an ovarian malignancy. So just to review the PCOS, so we have been using the Rotterdam criteria for diagnosis, which has oligoanovulation, hyperandrogenism, and polycystic ovarian morphology, which is distinct for these patients. And so both our patients had the similar symptoms, were marked as PCOS. However, the presence of solid adnexal mass and markedly elevated AMH raised the suspicion. So even in cases of PCOS, we can see there can be raised AMH levels. However, there is no standard cutoff of AMH which has been defined for this diagnosis, and we do not know a maximum level of AMH which is specific to these patients. So there's another study which is from the same institute, where we looked at the serum AMH levels among the different phenotypes of PCOS, and a cutoff of more than 6 had a specificity and sensitivity of more than 90 for the diagnosis of PCOS, although this is not yet in the standard guidelines. So when to suspect malignancy in cases of PCOS? So like chronic amenorrhea, like we had in our patients, persistent AUB, which is refractory to the standard management. And also we have to suspect, since PCOS is associated with risk of CA endometrium, presence of any thickened endometrium should raise the suspicion. So, and likewise, what we saw in these patients, there was an identification of solid complex cystic lesions in the ovary, which is not associated with PCOS, and there was a raised and persistent increase in levels of AMH. So what I want to tell here is the AMH decreases with the age, but if it is rising, we must think that there may be something else. So a little bit about granulosa cell tumor. So these are the rare sex-cord stromal tumors of the ovary. They account for only 5% of all the cases. And like our patients at adult type histopathology, this constitutes 95% of the subtypes. And these are often seen in women who are between 30 to 60 years of age. These are hormonally active, so they present with abdominal distension, pain, features of hyperestrogenism, realizations, or menstrual irregularities, as were there in our patient. Surgery is the mainstay of the treatment and carries a very good prognosis. So to coming back to our cases, so what happens physiologically is the granulosa cells in the ovaries will secrete inhibin as well as AMH, and what happens is this inhibin will have a negative feedback on the FSH. So when if we look at the hormone profile, both our patients had their FHS which was near to level of 2. And this affects the folliculogenesis, leading to secondary amenorrhea, infertility, and resistance to our routine ovulation induction agents and the IVF. For IVF, we use gonadotropin, those agents. Additionally, the very high AMH also blocks the new follicular recruitment. It inhibits the aromatase enzyme, which is essential for conversion of the androgens to estrogen. So when we reviewed the literature, we found that similar cases have been seldom reported in the literature, where with the presentation of infertility, secondary amenorrhea, resistance to ovulation induction, and gonadotropin, a small focus of solid mass has been found in imaging. These patients, all of them had an elevated AMH and LH-FSH ratio, and what was striking was there was a persistent increase in ovarian size despite treatment. These were the all cases. There was decrease in the level of the AMH, and most of the cases had spontaneous conception in the next cycle. So now coming back to the case again. So what was it? Is it a PCOS converting into a granulosa tumor or an existing GCT? So there we did not find any evidence which is association of PCOS with granulosa cell tumor. So it was probably a small granulosa cell tumor which was pre-existing in the ovary, which led to the symptoms. So we had, since both the patients were infertile and desirous of fertility, even this being a tumor, fertility sparing surgery can be offered to these patients. And this is from the latest NCCN guidelines. And this staging, as discussed, includes inspection of the cavity, collecting the cytology, then removal of the affected adnexa, partial omentectomy, and the peritoneal biopsies. For the stage 1, this is the adequate treatment as was for our cases. So our cases had both a return of spontaneous menses after the surgery. There was fall in the AMH and conception with the minimal dose of letrozole. So the key takeaways are, if when the endocrine profile and the imaging findings are discordant with our routine PCOS phenotype, we can think of a possibility of a hormone-producing ovarian tumor. Imaging plays a very important role, and if the TBS is not conclusive, we must go for MRI. Interdisciplinary team management is crucial for the shared decision making. Fertility sparing surgery is feasible, and the route of surgery, minimally invasive route, is safe. Thank you. Now I would like to call upon Rita ma'am for the final remarks.
Thank you, Swati. So these patients were actually being misdiagnosed as PCOS for last 2 years and 3 years. One was being followed up in Canada and getting repeated ovulation induction treatments. And when we reviewed her scans, actually this tumor was persisting for last 3 years. So maybe it was the indolent nature of the tumor. So it did not progress, but ultimately they could respond and the conception could happen only after we did the fertility sparing surgery. So anybody if has any query or comments, so please. Yes, the one patient who came from Canada, she showed us the previous reports also. So this was small; it was around 2 centimeter. Even it was there when she had undergone one pickup also. So she was not very clear that what did they do with the ovaries. She was not clear, and they said that there is some persistent mass, but nothing. Ma'am. Yes, ma'am. Yes, ma'am. Ma'am. The first patient, so actually we posted her for drilling. So it was just a routine scan. We thought because she had all the papers from outside AMS showing more than 18. So it was just routine scan we did in IVF. That Aarti actually pointed out that ma'am, there is something suspicious looking out. So we should see. So then we stopped that procedure of drilling and then we just changed the plan. So no ma'am, ultrasound. Yes, ma'am. Yes, ma'am. Ma'am, ma'am, this was the picture actually. This was the picture in when we did an IVF. So it was, it was
So
a bit different from.
I just want to ask, that's the solid tumor. There's anything else also?
Talking about dermoids, then there's the classic dermoid descriptors as there is an ultrasound ORAD. So if we are labeling it as a dermoid, then I don't think there should be any confusion. But when it's a lesion which is showing a solid area which is not shadowing, which is showing color flow, definitely an MR is indicated in those
So
cases
with
along.
this, then we requested Dr. Smita for MRI of this, and then by this time we repeated.
Ma'am, एक और image था ना, the other one.
Yes,
The
ma'am.
in
This
this
is the second patient, ma'am. This is
in
the
this patient, the first image can still be confused with the dermoid. No, in the second case,
Yes, ma'am. This is the second patient. This the first scan was done in Canada when she was following up there. So
here
there again there was some mass.
some lesion is
but,
there, yeah. But it is shadowing. Here, if
yeah, it
on
may
that
be.
spot, maybe
so
we can still say that it might
be
somebody labeled
dermoid.
it as a dermoid.
Yes, ma'am.
Yes. Yeah. Actually,
Hmm.
first image is looking like a dermoid.
Yes, ma'am.
In fact, when we reviewed the literature, even previously, some of the patients were looking like endometrioma or hemorrhagic cyst and had even received diagnosis. So when the other cases which have been
So
reported.
it was actually AMH. Actually, from 18 it became 48 within 2-3 months only. So and, and both the cases inhibin was more than 1,000. So
So can I say something?
yes, sir.
Couple of things I would like to say that, like in gynecological adnexal masses, generally we do the germ cell panel always. But I've noticed many a times this inhibin levels is something which is not always done. Okay, so that is something I would like to request my gynecological colleagues to add this one more parameter. It will help, in making a serum inhibin levels. That is one thing. And regarding granulosa cell tumor, these are well known to be estrogen secreting tumors. So many a times these patients we have seen, not in this situation maybe, but in others, that endometrial hyperplasia is very common in these patients. Thirdly, as we saw in the second case, they can be very hemorrhagic. Sometimes the tumor component per se is just a thin layer of tumor, that is all that remains, and most of it can mimic an endometrioma, and in imaging maybe even a dermoid cyst. And lastly, granulosa cell tumor, we should not just feel happy that we have treated
Yeah,
and
they have
they can recur. Okay,
Yes,
so
ma'am.
they have late recurrences after 7-10 years also, and around 20 to 30% of them do recur. So they have to be always on the follow-up, and when they do recur, they are very aggressive tumor. They adhere to all the bowel contents, and patient
Maybe
usually
we can
it's
counsel
very
them for
difficult
complete
to
surgery when the fertility is
So these are
complete.
the points I thought I'd like.
Rita, was that the endometrial thickness was normal, 5 millimeters.
Matlab it was, ma'am, but in the previous OVA scans which she showed, the endometrium was just 5.5. It was not increasing. So there was a problem of thin endometrium actually. So which may be again because of this high androgen levels, high AMH level, which was causing thin endometrium. Matlab this was some
They are
paradoxical. Yes,
secreting
ma'am.
estrogen.
Yes, ma'am. But these patients, they went into amenorrhea. Ma'am, these patients, both of
Oh,
them, they
okay.
went into amenorrhea. So they were not responding. Their cycles were coming every 5 to 6 months. That's so with the progesterone. So for almost 2 years, they were amenorrheic. So
And endometrium was thin.
endometrium was thin, ma'am. Yes, ma'am. This is
Yeah,
also
which
different.
is contradictory.
Yes, ma'am. Because
Yeah.
because especially the first patient, AMH became 3 after
Surgery.
surgery. It means she's not even PCOS. Actually, she was just carrying the granulosa cell tumor, which was being misdiagnosed as PCOS.
Okay.
So the second
Very
patient had
interesting.
PCOM picture, but the first patient, the other ovary was absolutely normal. So we didn't do any drilling or anything in that. And she conceived
And she
within 3
conceived
months.
spontaneously.
She conceived spontaneously in the 3rd month, immediate reversion to spontaneous menses. So she's continuing.
So her other ovary was normal.
Other ovary is absolutely normal. It was not even an ovary which should be drilled. And the AMH also came down to 3 after 1 month of surgery. So that is why we did not go for drilling. So
Interesting. Very nice.
thank you, ma'am.
Okay.